Good afternoon, everyone. I'm happy to present a new technique that will make smile surgery a piece of cake for even novice surgeons. So, we have no financial disclosures to disclose. Smile surgery marks a paradigm shift from flap-based LASIK procedures to flapless refractive surgery, but it remains a challenging procedure with a steep learning curve and novice surgeons having multiple complications, especially related to lenticule misdissection. Lenticular misdissection results in suboptimal outcomes for the patients and nightmares for the surgeons. In a routine smile procedure, first after the docking and centration is checked and the laser is fired, so initially the posterior surface cut is made, followed by the lenticule side cut. Then the anterior surface cut is made in a spiral out fashion, followed by the cap side cut in a routine case. Now, in a normal smile surgery, conventionally, delineation is done on two sides, one for the anterior plane and one for the posterior plane. But this can result often in misidentification of the planes and initial unintended posterior plane dissection resulting in cap lenticular adhesion. To overcome this, we present the double anterior single posterior delineation technique with a novel release sign which we have described. In this technique, we recommend two areas of anterior plane delineation and a single central area of posterior plane delineation centrally. And we suggest differential maneuver of entering for the dissector for delineation of anterior and posterior areas. So the red arrows mark, sorry. So the red arrows mark the anterior plane delineation and the so you can see that for the anterior plane delineation, the video is not playing. Excuse me, the video is not playing. Can you reopen the presentation?
Which 5 laser you are using?
So we suggest differential maneuvering for the entry of the dissector for delineation of the anterior and posterior parts. So for the anterior plane delineation on the two sides, the entry of the dissector is done in a curvilinear fashion, first entering the area between the cap edge and the lenticule edge and then turning it inwards towards the anterior plane. Because the anterior plane is in continuation with the undersurface of the cap, with this maneuver, it's highly unlikely to enter into the posterior plane while doing the anterior plane delineation. The two sides are delineated on the sides for the anterior plane. Centrally, we enter directly in with a slight posterior pressure on the cornea to mark the posterior delineation area. Now, when you do the posterior delineation, you will find resistance at both the edges of the posterior delineation. This is what we call the double stop sign. So double stop sign has been described previously. Here we notice double stop sign, which gives a dual confirmation to the surgeon that the initial two areas were in the anterior plane and now this part is in the posterior plane for the surgeon. As you can see that the overlapping areas will mark the double stop sign. So now you have three areas, two on the sides which will depict anterior plane, whereas the central area which is depicting the posterior plane which you have delineated. Now when we start the dissection for the anterior plane, you enter from one of the sides with the long dissector. Now, as you go from the one side towards the undissected area and reach the second area of anterior delineation, there is a sudden release of resistance and the instrument moves freely. This is what we call the release sign. Here again, you can see that the dissector, as it moves across and goes to the other anterior delineated areas, there will be a sudden release of resistance that the surgeon feels here. So this gives again a reconfirmation to you that you are in the right plane for the dissection process. And the further dissection is completed for the anterior plane. When you do the posterior plane dissection with the long dissector, you enter from the central area. And because there is only a single area of posterior delineation, there is no release sign noted while doing the posterior dissection. Rest of the procedure of smile is completed in the routine manner. So We performed this procedure as a novice surgeon with less than 5 cases of experience, and in more than 60 eyes with varying myopic errors, there was no case of lenticule misdissection which happened. The advantages of this technique are that it's simple, reproducible, and very easy to adapt. It's equally safe even in low myopia patients where lenticule dissection is challenging. And it gives an opportunity to rescue the case even in cases of initial posterior plane dissection. But the biggest advantage of our technique is the multiple checkpoints that the surgeon gets during this smile surgery. The first checkpoint is the differential entry maneuver for different planes. The second checkpoint being the double stop sign. And the third checkpoint being the release sign. So you are multiple times sure that you are doing correct dissection. So to conclude, our DASP delineation technique is a simple, dependable, reproducible, and effective technique to perform smile surgeries even for novice surgeons. And rest assured, with the DASP technique, the surgeon as well as the patient is going to walk out with a big smile on their faces after every smile surgery. Thank you. Visumax. So newer platforms do have separate areas for it. Yes, but most like still it's less prevalent as compared to the Visumax, which is more commonly used, and especially novice surgeons many times would be having that machine only. Yes, yes, it's called clear technique that they have two areas separate.